Hi there, my name is Max Hardwick-Morris, and thank you for taking the time to listen to a presentation of our work about identifying preoperative risk factors for iliopsoas tendonitis using our novel iliopsoas impingement detection simulation. Iliopsoas tendonitis is a relatively common complication after total hip and hip resurfacing arthroplasty, and it has multiple causes, including excessive lengthening or offset changes made intraoperatively and large diameter femoral heads. However, it's most frequently attributed to an impingement between the iliopsoas and acetabular cup due to an exposed anterior surface of the cup. We have developed a novel iliopsoas impingement detection simulation and validated its utility in a previously published case-controlled investigation, and we now wanted to use this simulation in the preoperative context to understand risk factors that may exacerbate iliopsoas tendonitis. We hypothesized that iliopsoas impingement would be related to postural factors such as pelvic tilt and femoral rotation. This was a retrospective simulation study of over 450 patients. The inclusion criteria was patients that were undergoing total hip arthroplasty surgery who received a long limb CT scan and preoperative functional radiography, including a lateral standing pelvic X-ray and lateral knee X-ray. Iliopsoas impingement was simulated in all patients using our novel simulation to identify patients at risk of iliopsoas tendonitis, and I'll discuss this in greater detail in a few slides. And these patients were then matched to patients who were not at risk of iliopsoas tendonitis based on gender and age. So patients first undergo imaging, including the lower limb CT scan and functional radiography. The CT scans are then processed in ScanIP to segment the bony anatomy and landmark the necessary bony and soft tissue landmarks. Implants are then positioned in proprietary software according to a standardized parameters. And finally, each patient is passed through the impingement detection simulation and categorized as either at risk or not at risk using the optimal cutoff point of impingement from our previous validation study. Several parameters were then compared between the cohorts, specifically standing pelvic tilt, native femoral head diameter, cup diameter, the difference between the planned cup diameter and native femoral head diameter, and functional femoral rotation. To provide some brief context, these are the main results from our previous validation study, which found that the simulation's output, impingement, significantly predicted the probability of iliopsoas tendonitis with a sensitivity of 74% and specificity of 100%. The cutoff point of impingement for these results was 0.16 mils. Therefore, in the present study, all patients with greater than 0.16 mils of impingement were identified as at risk of iliopsoas tendonitis. Looking at the simulation itself, we represented the psoas using 3 different segments that approximate the location and width of where the psoas passes over the acetabular margin and attaches at the lesser trochanter. Within each segment is a green path and a red path. The green path does not include the cup, and the red path does. Then the impingement is calculated as the difference between these 2 path lengths, which could be thought more intuitively as the stretch of the psoas due to the cup. Looking at the results, we identified 115 patients of being at risk of iliopsoas tendonitis. As mentioned, these patients were matched to patients who were not at risk of psoas tendonitis, and the differences between the cohorts were assessed. We found no significant differences between the at-risk and not at-risk patients for native femoral head diameter, cup size, and functional femoral rotation. However, we did observe that the at-risk patients had significantly more posteriorly rotated pelvises in standing and had a significantly larger difference between their planned cup size and the native femoral head diameter. So iliopsoas tendonitis is understudied, particularly from a standpoint of computational modeling. We have now validated a novel simulation for detecting iliopsoas impingement and applied it to the preoperative setting in a large simulation study to determine risk factors. The main findings were that iliopsoas impingement is related to pelvic tilt, and there is a strong association with the difference between cup size and native femoral head diameter. Similar results have been reported by Odry and colleagues, who observed an odds ratio of 26 for iliopsoas pain when the cup size is more than 6 mils larger than the native femoral head diameter. Looking ahead, we want to incorporate the results of this study and our previous validation study into our preoperative planning platform as a risk of psoas pain score to assist in preoperatively optimizing cup position. Additionally, we're looking at extending this modeling to other soft tissue structures, such as the capsular ligaments and the abductors, to ensure appropriate tensioning of the joint in our preoperative planning. Thanks very much for listening.